Assalamu alaikum. Well, I've presented about this subject in the past, and probably tonight this is the first time I say that there's going to be light at the end of the tunnel, as I'll take you through, and probably at the end the most important part of this presentation will be to update you on the UKC talks. We'll start off with what we probably all agree on, which is that ovarian cancer has a poor survival rate because it is often diagnosed at an advanced stage, and you need to do a major cytoreductive surgery, and if you're convinced with HIPEC, you might consider HIPEC. About 3/4 of patients will present in stage 3 and 4. The 5-year survival is over 90% for stage 1 disease, and about 25% only for those with distant mets. If you look at stage by stage across all the board in the gynecological cancers, is actually comparable. So the major problem is that those patients present late. So in order to improve survival, this cancer we need to find a way to detect it earlier. But there are risks and benefits to screening. The potential benefit is that obviously we can detect it early and deal with it and get a better survival. The risk is that a positive screening test for ovarian cancer most of the time is followed by either a laparoscopy or a laparotomy. To come up with an acceptable screening test, you need to come up with a test that would give you at least a positive predictive value of 10%. In other words, if 10 patients are subjected to surgery, you will accept to detect 1 patient. So nine patients will not benefit from the surgery. That's what positive predictive value of 10% means. To reach that endpoint, you need to come up with a test that has a specificity of at least 99.6%, a sensitivity of at least 80%. If we look at CA-125, unfortunately it is not of great use in premenopausal patients, and it is only raised in 50% of patients with stage 1 disease. It has limited specificity. It can be high in women, healthy women, fluctuates during menstrual cycle, and it is high in so many other diseases that are not malignant. It also can be raised in other cancers. So an annual CA-125, and you can see this being ordered, unfortunately, by so many doctors, believing that this would give benefit to their patients. Actually, they're harming their patients by just doing right off the bat just a measurement of CA-125 on an annual basis. Because alone it lacks sufficient specificity in an average risk population of postmenopausal women. Its use in premenopausal women, I've already mentioned this, that it is really not helpful. There's been at least three large screening studies that have shown that the specificity of a single CA-125 level for detection of ovarian neoplasm in postmenopausal women ranged from 98.6 to 99.4%, but unfortunately the positive predictive value was only 3%, i.e. you have to operate on 100 women to detect 3 women with cancer. Ovarian cancer was one of the arms in the PLCO trial, and actually I don't want to bore you with this, but this not only shown that it was useless, it actually was harmful. 15% of patients who underwent surgery developed major complications. If you look at pelvic ultrasound, the UKC talks, which I'm going to talk about in a few minutes, And it is the largest study to date. It involved actually, if you look at all the arms, more than 200,000 women, about 50,000 of them aged between 50 and 74, and those were randomly assigned through a multimodal screening method to ultrasound and to no screening. I'm going to skip the rest here because I have better results that have been released actually 10 days ago. This is important to grasp this multimodal screening. They still use the CA125, but they use it in a different way, and I'm going to mention it in a few seconds. The combination of CA125 ultrasound either performed sequentially, ultrasound only if the CA125 elevated, or concurrently. The multimodal screening and ultrasound strategies, and this is older results, and even back then those were still encouraging. They managed to show that the positive predictive value, if used through this ROCA, it's called ROCA algorithm, increased to 35%. So it had the MMS, the multimodal screening, had superior sensitivity and positive predictive value, which is now here, as you can see, is about 20%, and this is actually conforms to the most recent results. The ROCA is the risk of ovarian cancer algorithm. It's an algorithm that compares the CA125 profile of cases to that of healthy women and incorporates age-specific incidence of ovarian cancer in calculating the risk. What is more important is that actually they follow the trend of CA125. So it's a pattern. It's not only one measurement. This actually shows the important trials that looked at screening for ovarian cancer, and I'm going to just go through them quickly. The Kentucky study was a promising trial, but it was a single-arm trial, and it did show some advantages for screening, but it was only a single-arm trial. The survival data were as well promising. The PLCO I've already mentioned. It was an interesting study, but unfortunately it was negative, and large proportion of patients who actually had surgery developed, like 15% is a high number. I'm not sure what exactly happened there. I just missed there's a Japanese study also that was randomized, included 42,000 women. There was no significant detection in the detection of ovarian cancer at an average follow-up of 9 years between patients who received screening and control, and there was no significant, there was a non-significant trend toward earlier stage disease in the screened group. The most important trial, and I think by the end of this summer, there's going to be a major shift in how we look at screening for ovarian cancer, and probably this will be a major change in our practice. This trial, as I mentioned, randomly assigned more than 200,000 women. It's been going on for more than 10 years. What's going to come out at the end of the summer is the mortality data. So we're not only interested in studies that will show that they were able to pick up cancer. What we're interested in is to find a way to detect cancer early and prove that mortality is less. There's two screening arms. There's the ultrasound and CA125 followed by ultrasound. Again, the CA125 is interpreted using the risk of ovarian cancer algorithm. So this is where the secret is. It's the same CA125, but it's the way it's interpreted. And with their new publication, and I don't know exactly what this means, there's a new term called CA125 velocity. So I'm going to try to find out later what does that exactly mean. What I wanted to show you is this, what showed up on their site. It's UCL is University of Central London, and this was major news. It was released on the 5th of May of this year, that they were able to pick up twice as much cases of ovarian cancer. And this is published in May this month in the Journal of Clinical Oncology. Again, talking specifically about this point of the ability to pick up more cases of ovarian cancer at earlier stages. This has no mortality data yet. There's no mortality data within this article. This shows, if you look at the positive predictive value, here they look at, in the upper portion, they include the primary peritoneal cancer cases, and in the lower portion, they exclude them. But if you just forget about all the numbers, if you just look at the positive predictive value in the upper portion, you're going to see that the positive predictive value is sure. Okay. Oh, thank you. So here, the positive predictive value is 24%. If you look only at ovarian fallopian tube, if you include primary peritoneal, it stays very high. And again here, lower down, if you include the borderlines, your positive predictive value is still above 20%. That's amazing. That's even more than what I put out in my earlier slides, where I said 10% is acceptable. 10% you're going to get results. This is more than 20% of positive predictive value. I think I've talked about this. 41.4% of women were detected with stage 1 and 2. This is major. This is major news. Compared to a single threshold rule, the risk algorithm using serial biomarker measurement doubled the number of screen-detected cancers. The ROCA detected 86.4% of patients with cancer. Now, this is looking across the board, all stages, 86.4%. If you use CA125, a cutoff, just a cutoff 35, you can detect 41%. If you lower it down to 30, you detect almost 50%. If you lower it to 22, you detect 66%. But here, when you're looking at those percentages, this is all comers. We're not interested in all comers. We only want to detect early disease. And this is how you can affect mortality. And here, if you look, this is the same results, just looking at it in a different way. For each invasive epithelial ovarian cancer detected, 4 additional women underwent surgery. This again means positive predictive value of 20%. 80% will undergo surgery unnecessarily, and this is considered to be very acceptable. If we look at high-risk women, there's I don't think I'm going to go through this. This talks about another study that's going on, and still the final results are not out. This is talking about patients with familial ovarian cancer. It's called UK FOX. So at the moment, if we look at women with average risk before the results that we're expecting at the end of the summer, screening is not recommended. But I think this is going to change. But we'll meet next year, maybe we'll go through this, and we'll talk differently. As I mentioned, the mortality figure are still awaited. And this talks about how this UKC tox is promising. This is if you look at the USPS task force. I think this is going to change. But here it says do not screen. And this is just basically repeating some of the information that I mentioned before. Thank you.